I'm going to try and talk to you a little bit of an overview of how we treat ocular melanoma. And in this, I really want to try and introduce the fact that we've got a number of centres in Australia, in all the major capital cities. This is our group in Melbourne. I'm John McKenzie. I did my fellowship training in London. Dan Mackay, who we heard from yesterday, did his fellowship training in Liverpool after working with me in Melbourne. And we've got a current young trainee, Rod O'Day, who is currently working with the London group. So very clearly, as opposed to Sydney, where there is always a divide between the two cities, there's a transatlantic divide in our training. After I finished my training in London, I established the Ocular Oncology Unit at the AOMA Hospital in 1990. And as you can see, the AOMA Hospital was established in 1863, so it took a very long time for it to become a specialty unit. We're talking about rare cancers. So people have to remember that you can almost get a cancer of almost anything in the body. In fact, the one organ in the body that hasn't had a cancer is the lens of the eye. But the eye has got lots of pigment cells, so it's not surprising if you actually think about it that things can go wrong where there's lots of tissue of one particular type. So we heard a little bit about the epidemiology of this. In the 1990s, we carried out a study called the Environment and Eye Health Study. Over 3 years, we documented all melanomas that we saw in all these centres. That's where this figure of 8 per million population per year came up. That means that we've got 40 or 50 cases in Victoria. We said it wasn't UV related, but we didn't specifically hive off those iris melanomas, partly because the criteria for including the patients in the study was that they actually had treatment. And many of the iris lesions, even if they're progressive, we just watch them. So maybe we underestimated that UV component there. There's also a clearly ethnic variation in this. That's probably dealing with the Caucasian population. But when you go to Asia, and I've just been to Mongolia, where I saw one patient with an ocular melanoma in a population of 3 million, and that's probably about the number that they would get per year. As Max said, you can pick this up with symptoms or on screening, and I think that we're going to see more and more lesions picked up on screening, and particularly the early lesions. So I'm going to explain now why we have some Australian centres, and this is a photo taken from Earthwatch, which is where they're trying to look at the bright lights. And you can see that down the eastern seaboard, Adelaide, and over in Perth are our population centres. Unfortunately, New Zealand had their hydropower turned off on that day, but 2/3 of the population live right up the top of the North Island in New Zealand. This is another map looking at where people don't live and where the population is low. And you can see that our population is really centred in very, very small areas. And not surprisingly, those are where the centres are. So this here is to go really to an Australia-wide audience to say that we've got fairly well coordinated ocular oncology groups in all the major capital cities. There's a little bit of a transition in Adelaide at the moment, but they've got a fair amount of support from elsewhere. The main centre is in New Zealand, in Auckland, but as mentioned before, although the arrow is to Christchurch, in fact their radiation therapy for gamma knife is in Dunedin. So what sorts of treatments for ocular melanoma have there been? And this is kind of trying to put a list in order of how they appeared in development and importance. I really want to stress this issue of enucleation. One of the things that patients have taught me is that when you first talk to them about having an ocular melanoma, the last thing they want you to talk about is an enucleation. But for many people, it can be an active choice. For many people, it's the only practical choice. And I think that it's something that needs to be discussed with all patients. prior to enucleation, what happened was that your melanoma kept on growing, and eventually it will erode the eye and grow into the orbit. And whilst you've got a 50% chance overall of dying with melanoma, if you have the eye lesion treated, if it gets into the orbit, that really becomes an effectively 100% therapy. And occasionally we see patients who refuse therapy, and unfortunately that's often the outcome. External beam radiation is a possible treatment, and I think that we're going to hear from Claire and Peter later on about external beam and proton beam therapy, so I'm not going to dwell on that. I'm going to talk about laser thermotherapy. And today that's largely used as an adjuvant therapy, particularly after plaque treatment. We're using it less and less as a primary therapy, simply because there are other treatments with a much higher local disease control rate. There's a dye-activated laser therapy, and under that is the Aura Bioscience treatment, which we've heard about today. They both operate on fairly similar principles, and I'm going to show you a little study that we did in Australia shortly. Then I'm going to talk about the second, or the most common form of conservative treatment, which is plaque brachytherapy. Of course, with all of these treatments, we're hoping that we find other therapeutic agents to deal with the cell biology, and hopefully we can use it in an adjuvant treating setting with all of these. So I'm going to refer to here to Bertel's time in Liverpool, and I've chosen Liverpool because it's a treatment centre which has got many different therapies available. And this was some figures produced by his successor there, and it broadly shows in 2016 what they did. Enucleation is still a significant treatment choice. Ruthenium plaque treatment in 30%, protons in roughly the same order. They do surgical excisions in a small number, and they also observe a small number of lesions. Now, these are clearly lesions which are perhaps at the margin of being diagnosed as a melanoma rather than being truly a melanoma. This is their treatments over a period of time, and whilst there's a fluctuation in the percentages and patient numbers, you can see that those relative proportions remain much the same. So if you want to compare the treatments being offered to you as patients, I think you've got to have a look at what else is being done in major centres throughout the world. I'm going to now talk about where we got to with plaque radiation therapy. When I was at St Bartholomew's Hospital, I came across a patient who first went there when he was 5.5. This is back in 1930. He had retinoblastoma, and the eye, this one here, was essentially destroyed by the tumour of childhood. He had a lesion in this eye here, so it was clearly a threat, and they didn't have many other treatment choices. So what they did was they put in a radon seed. They sort of stuck it in through the sclera. You can see it sitting in here. And over 50 years later, that's the outcome. He's still got an eye. Most of the retina's been wiped out by radiation change, but so has the tumour. And he still had a little bit of navigation vision. Not great, but a better outcome than having to have both eyes removed. Foster Moore was the consultant, and his house officer was Stallard. And Stallard then went on to try and refine this, because dealing with radon seeds is not only dangerous to the eye, it's also dangerous to the surgeon, because they've got high energy radiation coming out of it. So they developed these cobalt plaques. And this here is to show that they were developed primarily for retinoblastoma patients. They had a treatment depth, and it also shows beyond that this is a gamma ray source, and it also damages the retina right out to this sort of margin. They didn't then applied these plaques to melanomas after Stallard had finished his war service in the Second World War. And they knew that melanoma was more radio-resistant, so they doubled the dose of 40 gray up to 80 gray, and then they added a bit of a safety margin, and they started off with 100 gray. And whilst they watched their patients, they also looked at their cancer registries, and their feeling was that they were getting no more melanoma deaths prior to this treatment when their only treatment source was an enucleation. And of course, in those days, it was often difficult to get your patients back to actually check on where they were up to. So things like cancer registries are very important. The problem with cobalt plaques is, though, that they've got very high energy radiation. It's both dangerous to the operator as well as the retina of the patient. And so they've gone on to develop other forms of plaques. Here we're talking about having a plaque with a shield at the back, so if the radiation is not going to penetrate you, you're not going to radiate the orbit. And the idea of this is to apply the radiation really close to the tumour, so you're not having to go through any other structures. You'll get quite a lot of damage right at the point of treatment, but you're not going to get damage elsewhere if you can apply a plaque very close to the tumour. Here's a plaque on the sclera with a tumour sitting inside the eye. As I said, the most important thing here is, of course, where the tumour is, and I think we saw Jody Rich saying his problem is that it's right next to his fovea, and that means that if you are going to put a plaque on, you've got to deal with how close you're going to treat it to the fovea and what the effect of radiation to the side of the plaque might be. One of the good things patients like about this is that you can be seen and have your plaque treatment fairly quickly. It does take a few days for it, but it's something that can be usually put in place in a fairly short space of time. This time we don't really have any guideline for how quickly that should be. That's something that we'll hopefully work out in the future, is what your expectation of diagnosis to treatment time should be. But it's something that we're trying to work on with guidelines. We also use these plaques for other things other than intraocular melanomas. Certainly ocular surface disease is an important part, but we also occasionally use them for other rarer tumours inside the eye. You need two operations, one to put it in, one to take it out. We often do ours under local anaesthetic, but you can have a general anaesthetic if you wish. And clearly the time the plaque is left there depends on both the tumour size, because the more radiation you need with a taller tumour, and also depends on the activity of the plaque. Those ruthenium plaques we showed you last about a year, and that means that by the end of a year they've got a half-life of about a year, that the treatment times take twice as long. So we heard a little bit about this debate of ruthenium versus iodine. So what are the differences? Well, ruthenium's good to deliver a high enough dose to about a 6mm depth. That means once you've got 1 millimetre of sclera and 5 millimetres of tumour, you're starting to deliver a lower dose than the prescribed 85 gray to the apex. Now, that may or may not be an issue, as Claire mentioned, and she'll probably mention again. We don't really know the minimum dose required to treat, but these also treat with a very high dose to the base, and it may be that we're actually able to treat lesions which are taller than the standard 5mm height of tumour. An iodine plaque has little iodine seeds, which, as we said, are activated. They're then placed in a holder, and that's a little bit more flexible, but also a lot more fiddly, because someone's actually got to do that. That's showing a comms plaque. They've got a much shorter half-life of about 60 days. So a set of iodine seeds in our hands will last for 3 or 4 months. I said that what sort of shape are these plaques? Well, these are all of the plaques that Baybig produce, and there's only one producer of ruthenium plaque in the world. However, if you look at how many they produce, their biggest seller is this one here, 20 millimetre diameter, followed by 15 millimetre diameter, followed by this one here, which is a 25 millimetre diameter, which can also fit around the optic nerve. With the COMS study, they had various plaque sizes from 10 to 22 millimetres diameter. Some of that was dictated by the fact that they wanted a couple of millimetres on each side of the tumour when they were using it, so they actually had quite big plaques. This here is just showing, again, the common sizes in order of popularity of sales, and that tells us that most of these lesions are fairly regular in shape. They're a dome shape, they're sort of round, but not all of them are. So there is a gold-backed plaque on an eye. We saw a photo of that earlier today. In order to place it over, we've got to find the tumour inside. We use transillumination. We shine a light through the pupil, or we use indent the sclera whilst looking with the ophthalmoscope. That's something we can do under anaesthetic. We mark it out, and then we attach the plaque to the sclera with little sutures, and we remove it once the dose has been delivered. We may have to remove muscles and various other things as part of that. The Collaborative Ocular Melanoma Study chose to use iodine, and it's still the most common agent that's used in the US today. And the important part about this is that they were trying to do a randomised trial of enucleation versus iodine plaques, and they found no difference, or no statistical difference in survival outcome. And that really confirmed what most people felt looking at their cancer registries before that. We've heard from a number of patients here that they're very concerned about their vision. One of the things that we can do is start thinking about radiation planning for plaques. And there is planning software. One of the downsides of planning software is, though, that we're often very much limited by where we can place the plaque according to where the tumour is. So our first priority must always be tumour control, but we also need, when these are close to the vital areas of fovea, optic nerve, and to lesser extent lens, that we can consider this when we're doing our treatments. Here is just some isodose curves that come from that, which show that we can avoid the lens here, and we can avoid, where practical, or give you really information about your risks of those various forms of treatment when we're choosing between different therapies. This here's a fundus photo showing that we put the photo into the planning program. These here are the lugs on the plaque, and we're going to put a plaque over this. You can put in imaging from CT and MRI, as well as ultrasound images of eyes here. It creates a very detailed plan of where all those isodose curves are going to be. Although, as I said, if you were able to choose where the isodose curves are by altering certain parameters, that would be good, but very often there is only one place that you can place the plaque. One of the things, though, we should consider is this issue of custom plaques, and this program here is promoted by people who custom make plaques. This here is showing a gold plaque with two lugs. The idea is it will sit over a tumour here, it'll go round the optic nerve, and you fill this in here according to what you need to treat and what you're trying to avoid treating. This is a slightly different sized plaque, a much longer one, wrapping right around the optic nerve, and you can treat lesions which go around the optic nerve with these sorts of plaques. This one here, however, is limited to slightly more anterior. So they can make a plaque of any size and shape using iodine seeds. And if we're thinking about expensive treatments, and I think we're going to hear a little bit about external beam radiation options, adding this to our armamentarium is something that we should consider, but it should all be considered on the basis of radiation plans rather than what's available or not available. This is something that we can exercise choice in. This is a picture from Claire talking about stereotactic radiation, and it shows that she too can apply radiation just to the lesion at the back of the eye here. Unfortunately for her, that tends to be where the patients we send her, and of course we know they're not going to have great visual outcomes. This is talking about using plaques with little barriers there to try and direct the radiation. This is a standard comms plaque, and you can see it has radiation that extends out beyond the sides along the retina. It is possible using little baffles in here that you can actually direct the radiation more in the direction of the tumour, even whilst using iodine seeds. In Dunedin, they've got slightly different technology. They've got a gamma knife, and when we were moving our radiation equipment... Sorry? Oh, what? Oh, have they? All right. Okay. They use... Thank you, Claire. I was making assumptions. But this is a classic patient that we would send to Claire with a lesion on the over the optic nerve, and we can't really treat that adequately by plaques, and that's where lesions are certainly around the optic nerve is one of the ones that we do tend to send to our radiation therapy colleagues. It's just showing the ultrasound of that lesion. It's got a height there of about 5 millimetres, so it's not a large lesion, but it's not something that the patient necessarily wants to have their eye removed from. Skip those ones. So what's so difficult about treating ocular melanoma? Well, I think that what we've seen today is that this is an obvious lesion. It's extending around the optic nerve, it's elevated, it's pigmented, and that's always just going to be a melanoma. But this one here started off life likewise as a small lesion. I think one of the things Max talked about is making sure that we have some sort of follow-up program for that sort of thing. This is another patient we've seen recently through an optometrist in country Victoria. A little bit of pigment scattered around here, a little bit of drusen over here. Seen the next time, wasn't referred to us, but clearly this is an enlarging lesion. When we saw it, it's really quite extensive. And on ultrasound, it's developed some height. And probably we should have seen this lesion much earlier and thought about treatment, even though it's difficult to start treating someone with relatively good vision. So Max also talked about screening. We've got to make sure that most things that we see are pigmented. They're going to be small nevi. There are a small number of other things. It's always important to make sure that when you get diagnosed with a pigmented elevated lesion, it's not always going to be a melanoma. And even if it's poorly pigmented, most of them are still going to be melanocytic lesions. They just don't express much pigment in them. We don't think there's much difference in terms of treatments or outcomes depending on their pigmentation extent. We there talked about with Max this issue of what happens if you've got a large nevus or a small melanoma. And they observed some of these small melanomas, or nevi I should say. They were clearly within that range which Max showed us the slide of under 2.5 millimetres in height. They still had a mortality melanoma related, even though they didn't treat them. But you've also got to look at the population. What should you be worried about if you've got a melanoma? And one of which is that they've got 5% of other causes of death other than just melanoma. Are they safe to observe? Well, it depends on your own personal risk level and your risk level for actually having it treated. This is the Helsinki study looking at the fact that even at 35 years out, if you have a melanoma as a young patient, your risk of metastatic disease keeps on continuing. So surveillance is very important with our oncology colleagues. Max talked about the risk factors, what makes this a melanoma rather than a nevus. These are some of the issues that we would look for, and we're trying to find these lesions much earlier and actually think about therapies earlier. It's looking for lipofushkin, looking for fluid with ultrasounds and OCTs, which is another test that you may have had. But not everything that's elevated and pigmented is actually going to be a melanoma, so it's very important to make sure you get a clinical diagnosis. This is a benign lesion called a melanocytoma. It's a congenital pigment abnormality that can occur inside the eye and is classically non-progressive. So that's plaques. I'm going to now talk about lasers. And we have got both photodynamic therapy and transpupillary thermotherapy. I'm going to talk about the second one first. I'm not going to show pictures because it's very difficult to show, but it's using an infrared heating laser delivered by a slit lamp, taken up by pigment in the cell, in the eye. And it's got a higher failure rate than plaques, so we tend not to use it as primary therapy, but it's certainly got a role in adjuvant therapy. You can also use a dye-activated therapy. It's intravenous. It's got a long wavelength, specific wavelength laser. It's got a few issues about how far the laser will penetrate in normal treatments. And we've done a study which was called ANZSOPICAM, and it was for poorly pigmented lesions, and it was done as an Australia-wide study. Those are the people who were involved with it. It's now about 10 years since we did this, and we enrolled a number of patients. We had a wide variety of tumour heights. The one stipulation was that they didn't have much pigment in them. We did this laser treatment 3 monthly until it was flat or a stable scar. Some of them fully regressed, some partially regressed, some didn't respond at the time. We had a non-melanoma related death. Clearly, the advantage of laser is you can direct it away from the fovea if that's where the tumour is. But local recurrence, particularly around the edge, was a problem. And so we now tend to use it in certain circumstances, but it's really, I think Jodie Rich showed us that there's a better way of getting that that dye which can be activated with light to the actual tumour cells, and that's that new Aura Bioscience study. So it can be vision sparing, and that's the real advantage of a laser-based treatment, and it's therefore one that some patients might choose, particularly when you've got a problem near your fovea. We heard from Bertel yesterday about surgical excision. So you can either do it from inside the eye with a vitreous cutter, you can do it from external. At the Ioneer, we do this with conjunction with our vitreoretinal colleagues. We do about one a year for primary treatments, usually for taller lesions, where treating it with radiation would lead to significant visual loss, and often with a smaller base. We'll often combine that with a plaque treatment to the base to be absolutely certain, because you don't want edge recurrences. Sometimes we use this as a secondary treatment for this toxic tumour syndrome, but really we're only doing that occasionally in the follow-up, usually of larger lesions. For exo resections, we're using that mostly also about one a year for small anterior ciliary body lesions or anterior segment lesions. We're trying to introduce tissue biopsy and tissue banking. We're trying to do clearly biopsy and banking for enucleations, and that's pretty straightforward. There's a bigger question though when it comes to treating lesions with plaques. We're trying to do biopsies for lesions transsclerally when they're anteriorly, and we would need to do it transvitreally for the more posterior lesions. We're using it to both confirm the diagnosis for the patient. I think that's very important for patients, that they really want to know that's actually what it was. We're also trying to develop our prognostic testing, but we're having problems with actually getting enough sample for our technicians to actually get a result. In the anterior segment, we heard yesterday that they've got quite a lot of UV markers. We also know that they've got a low metastatic rate. And local resection or plaque or proton beam or external beam therapy is something that's been employed around the world. This here's a small elevated lesion in iris, which is essentially poorly pigmented, but it's got lots of nevi scattered all over it. And this is a lesion up the top, which is a bit unusual. It's a magnified view. It's using a slit lamp to show that there's a beam of light which is elevated here, and then it's back flat on the iris behind it. You can measure that with a high-frequency ultrasound. However, this is the more classic position, and this is actually a lesion which presented with hemorrhage into the anterior chamber, which we biopsied because we knew this was, or by excision, we knew this would be a progressive lesion. It came back as an epithelioid cell lesion, and it's had no local or systemic recurrence. And lack of systemic recurrence, even with aggressive cell type, is what we would normally see. Clearly, these lesions live in a different microenvironment to the posterior segment. And we've had Jess talk today about the less common part of conjunctival melanoma. And one of the things that we want to make sure of is that people where there's even a potential for this have a proper excision biopsy rather than just a diagnostic biopsy, which would often be done for other odd bits of conjunctiva. Your prognosis depends on where it is. It can be just at the limbus, near the edge of the cornea. It can be on the eyeball itself, or deeper into the fornix or on the internal part of the lid. Classically, we do a surgical excision because most of them are at limbus, and we've got a very narrow margin compared with skin. So immediately we've got a bit of a problem, but we don't have an option for a bigger margin. There's a role for looking at nodes, although as in Jessica's case, she developed systemic disease rather. There is a rate of recurrence after this local surgery, so repeat excision and radiation plaque is how we try and deal with those. But if it is aggressive and progressive disease, sometimes we do need to advocate for enucleation or orbital exenteration in order to get an adequate treatment margin. Clearly, though, for those aggressive diseases, we need to think about systemic therapies rather than local therapies. Freezing and mitomycin C is also employed in this sector, and that's something that some people will have discussed with their clinicians. So I'm just going to finish off by showing what is conjunctival pigment. Some of us are just born with it, somatic. You can have a nevus, which is a benign lesion which can progress slowly, particularly if you develop cysts. Sometimes they become inflamed. You can have acquired melanosis, which is similar to lentigo maligna on the skin, but you can also have melanoma. This is a patient with a large conjunctival melanoma, and we can all recognise that. Smaller bits. This has probably arisen in an area of acquired melanosis, so that's pre-existing but progressive pigment. But one of the things that we as ophthalmic oncologists need to be aware is that sometimes, whilst this may be largely a squamous disease, you can get squamous cell cancers and its precursors. Sometimes the biggest problems that we see is where someone's got a poorly pigmented lesion and it isn't dealt with adequately by full excision at the initial time. So where are we going to go from here? Well, one of the things I've been pushing is this concept of care pathways. They were developed initially in Victoria to try and make sure that people in country Victoria got access to things like radiation. And eventually these pathways were endorsed by other cancer councils. But we missed out in ocular melanoma because we're a rare cancer. Even though the person at the health department guiding this was both my surgical consultant in my first year of clinical practice, and he also operated on my mother. He always apologised for not being able to fit us in. So we're trying now to develop clinical care pathways. So I've stolen this photo from my friend Mark Shackleton. It's the end of my talk, but collaboration is the thing that's going to give us the force to go on. Thank you.